Okay, good afternoon, everyone. So I should have titled this Updated Public Health Nursing and Mass Care Settings Back to the Future, because I think that's what we're going to really be talking a little bit about today, since extensive changes that we've made to Annex H and the guidelines as we've moved from going to using non-congregate settings such as hotels. That funding is gone, back to congregate care settings should we need them. Luckily, hurricane season, that's usually our biggest source of emergencies, has been quiet so far, although Southwest Virginia, you've been taking more than your usual fair share of hits with the floods that you've had. Next slide. So I wanted to share this definition of public health nursing with you, and it really sort of highlights that public health nurses are not acute care nurses. We provide niche services for specific populations. We are also not first responders in mass care settings. We are first receivers. So once the initial, shall we say, event happens, first responders will respond to any life-threatening situations on the scene. We get the people who have either fled previous or who are stable enough to be moved into our care, usually. Public health nurses and volunteers, and I'll say this several times, must hold basic life support credentials to serve in our shelters, but please keep in mind that most of our nurses are not ACLS, Advanced Cardiac Life Support Certified, or Pediatric Advanced Life Support PALS certified. And we're really primarily involved in prevention, not in tertiary care. Next slide. So I've given you some documents here that we've updated, and this concept is reinforced in all of these documents. So basically, again, in Annex H, it states that public health nurses typically provide triage, health assessments, limited medication administration, and case management. Again, we have a VDH nursing directive that was developed with extensive input from university professors at Shenandoah University, and who are experts in disaster response. And we're really looking at the needs assessments of communities impacted by the incidents, population-based triage, mass dispensing of preventative or curative therapies, community education, and really looking at essential public health focuses and services. So we are not acute care nurses. Next slide. So the Association of Public Health Nurses, the World Health Organization, have also focused on preparing nurses for disasters, and the real focus for this is keeping folks safe for the amount of time where they have to be out of their normal environments. It's not providing a tertiary level of care. The WHO guidance, which was updated in 2019, also focuses on knowing the framework for ICS response and what basic triage, which is a key principle of being able to safely care for people, what that entails. A lot of this guidance was also developed looking at the regulations governing the practice of nursing and when we can deploy a nurse and what is the scope of practice, Code of Virginia restrictions on nursing and nurse practitioner practice, and ANA documents on ethical practice, including patient safety. Our goal is to provide safely for the clients that enter our shelter services and to keep them stable and not needing to go to a higher level of care. Next slide. So I put this slide up here. A nurse is a nurse is a nurse. Well, a plumber takes care of pipes, your cardiologist takes care of pipes, and your urologist takes care of pipes. But would you want your urologist or your plumber doing your cardiac surgery? I don't think so. So when the community says a nurse is a nurse is a nurse, they need to understand that nursing has become increasingly specialized. I was at the VNA conference this year, and even the smallest community hospitals no longer typically have a quote-unquote med-surg floor or a mixed med-surg floor. nursing has become increasingly specialized as the care of individuals has become increasingly specialized, and the technology needed to provide that care has become even more sophisticated. So you need to plan and really communicate with your community partners that a nurse is not a nurse is not a nurse. And there may be situations where we can't handle what comes through our door. And we need their partnership both to understand that and to prepare for those folks that we will not be able to accommodate. Next slide. When you look at the International Council of Nurses competencies for disasters, they're also looking at planning and preparation, and that's have a plan. Disasters are becoming more common. They recognized this in 2019, pre-pandemic. Climate change is fueling a lot of these disasters, so we do have more intense storms. We're seeing that now in Pakistan, and there's a lot of focus on making sure the nurse is part of the solution and not the problem. So it's really important to work with your nursing staff ahead of time. Don't just kind of give lip service to, what is your plan? Rehearse it with them. Practice. Make sure they're prepared to be deployed. And I'll go over a little bit at the end of this presentation about responder stress. And I think that's one of our takeaways from previous deployments was the folks that were the least prepared pre-deployment had the most issues post-deployment. And they also struggled the most during the deployment. Knowing the structure is extremely important. That's been pointed out in the Association of Public Health Nursing competencies and the ICN competencies. So knowing incident command structures and what is expected of the individual, having very clear roles and responsibilities when you get to the shelter, and having a good sense of what is safe practice and what is not safe practice. So your goal, again, is not to provide tertiary care. That's what they'll get from their level 1 trauma center or when they have to, send them out. Your goal is to keep the folks that you have in the shelter as well and healthy as you can be for that time that they're outside of their normal environment. And then we're really looking at recovery post-disaster when we're seeing more and more folks are not able to return to their previous home or previous place of residence after the disaster. And what does that long-term transition look like? And we'll be talking about some transition actions for nurses when you get ready to close your shelter down. Next slide, please. And again, just letting you know, the Association of Public Health Nurses also emphasizes that public health nurses' strengths are in assessing needs, disease surveillance, case management, and first aid. We simply cannot be reviewed as acute care, hospital replacements, or first responder extensions. And I would just definitely encourage your nurses to be empowered to speak up when they feel that it is not within their scope of practice or scope of training, because our goal is to protect the public and keep them stable. Next slide. So the Code of Virginia speaks to maintaining current competency. For the Virginia Board of Nursing Regulations, it says 2019, I forgot to update that, they were just updated last year, but the statement here stays the same, is that we are forbidden from assuming nursing duties and responsibility within the practice of nursing without adequate training or when competency has not been maintained. Typical rule of thumb on competency is if you haven't done it in 2 years and nobody's assessed you, you should no longer consider yourself competent. For a lot of tasks, I would say that really is for 1 year. So if you've got a nurse who retired from the ICU 6 years ago, and you have a chronic vent patient from a home that comes in, you can't assume that that nurse that was in the ICU 6 years ago is still competent to take care of that patient. There are some things that we'll talk about that you can facilitate the caregiver maintaining control, but you really want to think about when was the last time the person performed this task and how do you verify competency. So you need to verify the competency of your nurses and MRC volunteer nurses prior to your emergency. This typically falls to your nurse manager. Nurse managers who are public health nurses typically also do not have acute care skills. So my suggestion to you is really stick to what we have said in the nursing directive are within the scope of practice of public health nurses, because that's what you're deploying your MRC volunteers to do when you're looking at how you staff your shelters. Folks have asked me about partnering with staffing agencies. My only reminder to you on that is that the staffing person who hires the nurse from the staffing agency is responsible for their competency. So do not assume that just because you're getting a nurse from a hiring agency that what you're getting is a well-trained, competent nurse. It's easier to check that competency in the hospital where you have people who are up to date and these folks aren't practicing alone. But remember, you're bringing a lot of folks into shelters who may just be practicing with one other person and with very little clinical backup like you have in the hospital. So there's no way to call pharmacy and check a med. There's no way to double check a procedure, run it by a doc or a resident, because there's nobody going to be there with you. So think about those things when people are asking you to do more in a shelter than you feel like your nurses are able to do. So some key concepts for this training. Again, our functions are triage, assessment, disease prevention, case management, and first aid. Nurses have to remain within their scope of practice and what they can do without a physician's order. Nurse practitioners must function within the scope of their practice. And just as a nurse is not a nurse is not a nurse, nurse practitioner is not a nurse practitioner is not a nurse practitioner. There are 8 different types of nurse practitioners licensed in the state of Virginia, and each one is licensed based on the competencies that they learn in their training. So family nurse practitioners can treat folks across the lifespan, but a lot of our health districts employ women's health practitioners or nurse midwives. Their scope of practice is very defined and very limited. They can't just write an insulin order for a 64-year-old diabetic. That would be considered outside of their scope of practice. So those are some things that you need to think about with who's manning HDOC for you and who you're going to bring in to write orders and replace medications for folks that have lost them. Again, please carefully review the Public Health Nursing Directive on providing shelter services and share this information with your community partners. At the VNA convention this past weekend, everyone was pretty aware that part of the nursing shortage is we have a mismatch of where nurses are and what they're trained to do and where the need is. So again, even in the acute care setting, it's matching the training of that nurse, the competency of that nurse to the task at hand. Most of the hospitals, CEOs that I talked to this weekend also said the same thing. You know, they're looking for nurses. It takes about a year to change specialties for a nurse unless you're subspecializing in a hospital setting, and they're setting up ever more nurse residency programs for experienced nurses who are looking to move from the NICU to the adult ICU. They may be shortened periods of time, like 6 months versus 1 year, but it's taking that long to train folks. So that is how intense the medical environment has become, and I think we all just need to be aware of that. Next slide. So just a word on triage. Triage is a function of public health nurses, but the regulations governing the practice of nursing in Virginia describe triage and put it under the purview of a registered nurse, a licensed medical practitioner, which would be a physician, a nurse practitioner, yes, again, if the people she's triaging are within the scope of practice. Otherwise, they revert to a registered nurse, which they all have a registered nurse license, or licensed dentist. If you're using an LPN and assigning them to triage, they have to be under either a registered nurse or a practitioner that could supervise them, which could be a physician, physician's assistant, or dentist, although I can't imagine a dentist doing medical triage, but there it is. But this is in regulation, and we can't skip over it, bypass it, or stretch it. Next, please. So we've done pretty significant updates to the triage in Annex H. And what we've basically done is removed all of that COVID triage that we had during COVID and really reverted back to the old screening form, because you're thinking COVID, but you also need to be thinking flu and other communicable diseases. We're already seeing flu circulating in the community. That's very early in the season for us in Virginia. We're seeing high rates of RSV. New York had to declare an emergency for polio. Quite frankly, I can't imagine a noro outbreak in a shelter. That would almost be the worst case scenario, I think. But those are the kind of things that we also need to start thinking about when we open shelters. And we've added some updated infection control information into Annex H that HAI helped us to develop to make it more friendly and aware for other communicable diseases. Slide. So the triage form is rather long. It asks about medications and do you have them with you and everything. But we know if this is truly an urgent situation and we need to get people inside the shelter quickly, there is a rapid verbal triage that you can do for folks. I think you remember during COVID, we had you screening folks for temperatures, requiring masks. Now we're just saying, ask these questions. This should get at the heart of whether or not you can come in safely to our shelter. Do you feel healthy? Have you recently been ill or sick? Do you have a rash? Let's hope it's not monkeypox or measles. Again, fever, cough, sore throat, nausea, vomiting, diarrhea, all those things that we typically think can signal issues that could be communicable or have red flags to put in the general shelter population. We've gone back to all that. And then the other thing that we want to know is, do you have any severe environmental, food, or medication allergies? And if yes, do you have an EpiPen? So we'll talk a little bit about EpiPens and naloxone later on in the presentation about how to handle that as well. And then, do you have any special medical conditions that require accommodation? I'm hoping that will elicit everything for you that you need to know about supplies, but also clue you into folks that are being treated for opioid use disorder and who are in medication-assisted treatment. And there are some provisions in Annex H under Section G that will talk about what you need to do if those folks are showing up at your shelters. Next slide. So when you look at the triage algorithm, it really reverts to that pre-COVID algorithm. Do they have a medical condition requiring specialized care, treatment, or accommodations? No. Definitely go to the general admit shelter. Are they self-sufficient? If they are self-sufficient, we can admit them to the special needs section of the shelter. Can we accommodate their need? And I'm going to talk a little bit about some things that you need to think about when you're trying to determine, can we accommodate their need? Do we have room for them? Are they going to be medically safe to be in the shelter? If you don't feel that they are, that's when you route to see if we can find an appropriate place. That being said, we have had situations where we can't move people. Then your goal is to stabilize that person and keep them as stable for as long as possible until you can transport them to a higher level of care. Next slide. So some of the recommendations from HAI are to think about testing, but not just COVID testing when you are admitting people to the shelter. Look for testing for respiratorily spread disease that have rapid tests. So we're talking rapid flu and rapid COVID testing, depending on the rate of transmission in your area. So if you look at the state map today, we still have some areas that are very high in COVID transmission rates. We have folks that are in low transmission rates where it wouldn't be as important perhaps to do the testing. I know most of our CLIA certificates are PPM, provider performed microscopy, which means we don't have any send-out labs. So if you're doing rapid testing, you've got to make sure you have CLIA wave tests, and you need to make sure all staff have been trained both in running the test, reading the results, and disposing of the test equipment once the testing is complete. I'd like to note here that you should not deny entrance to the shelter if people refuse to be tested. They have to give consent. And then you're going to need, and it's going to be more important than ever, to identify isolation and quarantine areas in your shelters. And I would encourage you, just like we did with COVID, try to keep family groups together. Most likely the individual that you're putting in isolation or quarantine has already exposed the other people in their family group, and it really cuts down on some of the anxiety if you can keep them together. We've also included in Annex H on the next slide this lovely graph from HAI that talks about areas that you need to be concerned about with infection control. So again, screening individuals to enter the shelter means screen them with that rapid triage form if you've got to get them in quickly. If you have time to do the full triage form, that's great. If you're, folks are trickling in, but see if you can hit the highlights. So screening folks who enter the shelter means also screening volunteers, residents, and shelter staff. Your staff should be very careful to be up to date, encourage them with their own immunizations, their SARS-CoV immunizations and boosters, their influenza, yearly influenza vaccine, or you should know who has the declination statement for that. In this day and age, measles, mumps, rubella, and the rest of your routine vaccinations as well. That's important for protecting both the folks in our shelters and our volunteers and staff. If you can, implement physical distancing among residents. So if you're planning on shelter, think about setting up your cots 6 feet apart if you can, knowing that you may need to put those closer together if you simply have more capacity than you have room for to keep them 6 feet apart. Don't make that a reason for keeping people out of the shelters at this point. In the Annex H also, there's a new form included that you can use to monitor for symptoms and signs of both infectious diseases and mental health issues daily in the shelter. It's a simple sort of question form that you can use should your shelter need to be open for any length of time. And you've got to have an isolation and a quarantine area in your shelter. Preferably those areas should have their own restrooms. I know that a lot of you guys use gyms and other type of large buildings, and that may not be possible. But do the best that you can, and this again, this is the ideal, and if you could plan for this in advance and think about where you're going to have your facilities, or if now is the time to be looking for new facilities to set up for shelters, think about these different things. When you're looking, knowing that your special needs population and your special needs shelter probably needs that physical distancing even more than your general population shelter. That may mean that you may need to plan for 2 special needs shelter rooms off of your general population shelter. Again, it's doing the best that you can. In Annex H, they also give some suggestions of possibility of using plastic draping material to try to reduce the spread of airflow if you don't have any way to separate it out into a separate room. It may not seem like much, but you can also put up screens. Something is better than nothing. You can provide masks to individuals, but especially in your special needs shelter, I don't think we can require folks to wear them, and certainly not in the general shelter either. And again, if you need to, be prepared to test. So have rapid testing available if possible. My understanding is that we are no longer pre-positioning the DCLS COVID tests, and if you need to go down that route, you're going to need to go through your usual channels to request those supplies.
And we had a question, do we have access to flu tests to keep on hand for shelters, or is that something they also have to purchase as a district?
So I don't know if we can actually order flu tests through DCLS, the rapid ones. They go out of date really fast. I can tell you that from working with them in the private sector. And that may be something to think about a partner with an FQHC to see if perhaps that would be a resource that would be available for either purchase, or if they've got Medicaid or private health insurance, you can usually bill on the back end for that, but you would need a consent. So again, these are all nice to have, good to think about. The logistics, I leave to my logistics wizards, Susie and Jonathan over here, to sort of figure out how we can get that on board. Flu tests, luckily, most of the rapid ones are CLIA waived, and we can do those be performed by nurses as long as they've had training to do them. And they're pretty straightforward to do. All right, next slide. A word about PPE. So I know some folks are still a little nervous about COVID, and we're okay with folks wearing a mask. But when you think about PPE, I think the last thing we want to do is show up at a shelter in a 100% hazmat suit in an N95 when there's really no indication that that is needed. PPE needs to be reasonable. Hospitals are seeing this as well. So in Annex H, there is guidance and links to the CDC site that describes the PPE necessary for different types of precautions. So check, depending on the condition that you have that walks in, check to see what is the isolation recommended for that condition and what is the recommended PPE to have there. I would say do have masks available for shelter residents and staff who choose to wear that. It is flu season, like I said, as well as COVID season, and that's reasonable, but again, use judicious PPE, but not, how shall we say, overuse of PPE. And then you also have some signage in Annex H, depending on the suspected pathogen, to post signs on the entrance to where you've cohorted those folks or clustered those folks. And they also let you know the appropriate PPE per CDC, PPE disposal, and what area disinfection is needed. So there's also a link to approved disinfection solutions in Annex H. Next. So for acute injuries in the shelter, of course, we're going to do triage. If people show up with acute injuries, our role is to provide first aid and life-saving measures if indicated. It's here on the slide in red. All nursing staff assigned to work in shelters as a nurse. This question came up from the last session of this. If you're not assigning them to a nursing role, in other words, they're just working to register somebody in the shelter. They are not licensed any longer as a nurse, they're retired, whatever. They do not have to have current BLS certification. But everyone else who's serving in the nurse's role has to have BLS certification. They do not need to be certified in first aid. If you have an active nursing license, your training has given you the background to provide first aid, but they do need to have the adult and pediatric CPR AED. So provide that first aid, notify the shelter manager if immediate transport to a tertiary care facility is needed. If you treat minor wounds and, bandage them up, clean them, whatever, you do need to record that in the nursing notes section. And there's a form in Annex H that will give you room for nursing notes. And then at the shift change, you should practice reporting off those individuals for follow-up to the next shift. Shelters aren't the best situations for maintaining hygiene and staying clean, so we want to make sure we don't have any wound infections, or that they don't have a chronic condition such as diabetes or impaired circulation that could cause that wound to get worse over a short period of time. So I'll be talking about documentation and saving that documentation a little bit later in the presentation. Next slide. The public health nurse's role for managing chronic conditions. Your goal is really to keep this person as stable as you can. And one of the best ways to do that is to allow them to continue their regime, whatever they're doing at home, that is maintaining their condition to the extent possible. So what goes on at home, as many of you who've worked home health know, is not necessarily what goes on in the hospital. So take intermittent catheterizations, for example. Urinary catheterization is intermittent. In the hospital, that's always a sterile procedure. At home, it's a clean procedure. And individuals may not use a new catheter each time. Remember, they're cleaning it, it's their germs, they're handling it in their environment. It's not like being in the hospital environment where we ourselves as healthcare providers are little germ vectors moving from room to room and spreading new and interesting bugs via urinary catheters. So however they're managing at home, that's how you want to support them. The same with tube feedings, the same with trach care. Your definition of excellent trach care may not be the definition they have at home, but it works for them. And the best that you can do is to provide them a clean area in the shelter and privacy to be able to take care of those needs and maintain that stabilization. So a lot of what you need to be looking at is, do they have enough supplies with them? We have more and more folks on peritoneal dialysis. Because it's just easier to be mobile with peritoneal dialysis than hemodialysis, and you don't need to worry about the shunts running out, wearing out over time. So we've got more folks doing those exchanges. If they have the supplies with them to do exchanges, they'll probably need a private room where they can mask, and whoever is with them can help do that exchange. If they don't have supplies with them, if they had to leave in the middle of the night, the way some of these folks did up in Southwest Virginia, if you can't transport them to a higher level of care, how long, their key questions are, how long can they go without doing an exchange before they get into trouble? And most of them will be able to tell you, and most folks, caregivers, will be able to give you that information. To the extent possible, arrange for a barrier-free environment. That means also taking into account cot height, the fact that there are no railings or bed stands on the edges of cots to help people get up and off cots and move around, particularly if they're elderly, and then considerations for our bariatric patients as well. And again, linking to either a primary care provider, replacing medications if you can, and replacing supplies. Next slide. So again, in assessing, think about, do they have their supplies and equipment to maintain stability? If we're looking at a hurricane and we can't transport because the roads are unsafe for 6 to 8 hours, do you think you can maintain that person's stability for 6 to 8 hours? Do the on-site medical personnel, particularly if this individual did not come with their caregiver, do the people on site have the skills to be able to assist that individual? And again, a lot of these folks can be self-sufficient with just minimal assistance. And would remaining in the shelter risk rapid destabilization of the individual? Those are all things you need to consider whether you keep them or not. Folks have always asked and said, well, the hospital won't admit them. If you send them to the ER has to come up with a plan before they can discharge him, and it's better to be in the holding area of the ER or the PACU for the overflow if it's not safe to be in your shelter. So you really need to impress upon your nurses that nursing judgment and pre-assessment of everybody's capabilities is key. And again, just because a nurse retired 5 years ago from an acute care setting does not mean that she's current. I have not given pediatric immunizations now in almost 8 years. I would not feel comfortable giving a pediatric immunization without somebody doing a refresher course for me and verifying my competence. I gave enough COVID vaccines and monkeypox. I think I'm good there. So you can call on me for those. Next slide. So care is becoming increasingly complex. And I think at the conference this weekend, talking to some of the CNOs, they're really moving to this new concept of hospital in the home. And I don't know if some of you have seen VCU is advertising for the staff to staff their hospital at home model, and several other hospitals are doing the same. So you will be going home with your IVs, your high-tech equipment, linked to remote monitoring from a central location. It's almost like remote ICU that you see where somebody in another country is monitoring your monitors and giving orders from half a country away. That's what we're seeing being brought to the home. All of that means there's never enough plugs. So if anybody stayed in a hotel recently, by the time everybody plugs in their cell phone, their computers, their iPads, their whatever, there's never enough plugs in a hotel room. With everything going electronic, there's never enough plugs in a shelter. So more than ever, I think, particularly with this move to more home care and less acute care hospital beds, you're going to see the need for power in your shelters increase. It's not going to go down. So that's something to really think about, and how you safely plug in all these machines. I mean, even my own dad has to keep his iPhone charged because he sends an EKG run through his iPhone. He sends it to the cardiology practice and they adjust his meds electronically. So these are folks that years ago we could not, even 5-6 years ago, we didn't have the technology to maintain that daily EKG in the home. Now we do. So that's just something to think about when you're planning for shelters. So a couple of special situations I'll go over next. So oxygen dependency. More and more folks are on oxygen. More and more of us are getting old. We need our oxygen tanks. But as most of you know, those small tanks are small. They are portable, and a lot of folks don't bring extras with them to the shelter. So really assess your ability to access supplemental tanks prior to the emergency. I mean, the EMS is one option people always want to go for. But remember, they need their oxygen for acute emergencies, and they can't run an entire shelter's oxygen over what they have on their ambulance. The other thing is to consider posting signs in your shelters if you have folks using oxygen. Sometimes you'll want to admit these folks to the special needs shelter, so to speak, but you'll find a lot of things that we used to consider special needs. Really, folks are out in the general population more and may appreciate the ability to move around a little bit better and freely in the general population. But I can tell you, having been locked up in a shelter for 8 hours with people who can't smoke, people get really creative about sneaking and really desperate. So if you post signs saying, please don't smoke, you might blow up the person next to you, which actually is not as big of a risk as we would think with those small volumes of oxygen. But hopefully that will get you a little bit more cooperation, perhaps, from folks who are just absolutely desperate for a cigarette in 150-mile-an-hour winds, and we can't unlock the door. True fact, I'll never work a shelter again unless I stop by CVS and pick up 15 packs of Nicorette gum to pass out to folks. Okay, next slide. Tube feedings. Less and less tube feedings. It talks about bolus tube feedings in Annex H, but you and I both know that fewer and fewer folks are doing bolus tube feedings. It's not as comfortable for the patient to do a bolus tube feeding. You get a lot of dumping syndromes, a lot of gastric discomfort. So a lot of folks really are going to either continuous feed or small bolus feeding. So with feeding tubes, you really want to know, is this tube the only way that they get oral intake at all? Or is it just supplemental for supplemental feedings? And can they, do any oral intake at all? Because hydration is going to be key for these folks that can't do any oral intake and have no way to plug in a feeding pump. They can get dehydrated pretty quickly, and if they can't get their medications flushed and down that tube, that's going to cause another issue with stability. So again, electricity is a key. Allow the caregivers to manage the tube. If it's just for supplemental feedings and they didn't bring the supplements with them but can still do hydration and meds, they're probably safe to stay with you. If it's not, particularly remember if they need seizure meds, this is not a good thing to let the levels drop while they're in a shelter. Next slide. So Annex H in Attachment G does have guidance for folks that come in on medication-assisted treatments for opioid disorders, and that they bring their Suboxone with them. We have had them lock up their Suboxone in shelters in the past. I think that's a good idea, but you want to make sure that these folks have access to their Suboxone during these times because they are stressed. With the pandemic, not only have we seen an increase in opioid use disorders and overdoses, although most of them have been fentanyl related, which unfortunately naloxone does nothing for. We've also seen a huge increase in alcohol use disorders. And even though opioid withdrawal is intense and quite painful and miserable, alcohol withdrawal, acute alcohol withdrawal can be deadly. So if folks self-identify, or if you have some concerns or family members voice concerns about alcohol withdrawal, or the fact that this person's going to now be without alcohol for 8 to 10 hours, be aware that that can be a life-threatening situation, and that's somebody that you want to be aware of sooner rather than later. Next slide. So a little bit about naloxone. So I really encourage you to bring naloxone to your shelters. We needed it at some of our vaccination sites, unfortunately. But you do have to dispense it to individual people, and you can't just put it in the stock shelter bag. So make sure your staff ahead of time are trained to deliver naloxone. It should be easy to dispense it to your staff so that they have it on site. You can take it to your staff on site as long as they have documented training on how to use it. And I think they really need to be aware that a lot of the overdoses were related to fentanyl. So it's especially critical if there's no response to the naloxone to get help sooner rather than later. Epinephrine is a question that always comes up in the shelters. Epinephrine auto-injectors, which I'm going to call EpiPens, even though that's a brand name for those. If you are going to use Epi for your shelters and take it to the shelters, number one, if you've got EMS on site, they should have Epi. So that may not be an issue for you. But if you don't have EMS on site, the quote-unquote expectation of the locality may be that you, as the health department, are bringing epinephrine. So they are not inexpensive, the auto-injectors, and there have been ups and downs in the supply chain. The supply chain eased a little bit over last winter and into the summer, but as all the schools opened up again this fall and everybody had to order new supplies, they were hard to get again. If you are going to bring them, make sure that they are in date when you bring them. And you need an EpiPen adult and an EpiPen junior, and preferably two. It's got to be a 2-pack. I would suggest, depending on the size of your shelter, that you have more than one kit to go. Your staff have to be trained to use the EpiPens. Don't assume that they know how to do it in an emergency. I can't tell you how many teachers that I trained that tried to use one that stuck it in their own finger when I was working as a school nurse, and that's can be a medical emergency for the person that was accidentally stuck, and it doesn't certainly help the person that needs the epinephrine. Also remember, if you're keeping clinics open when you open a shelter, or you're going to be keeping the shelter open longer, but you're going to reopen your clinics, you need to have enough epinephrine to be able to open your clinics. And that's a huge hit to your budget. So think through how you're going to do this and how you're going to do it safely to maintain operations. If you open a pod in a shelter, remember, you're going to have enough epinephrine to respond to supply emergencies within that pod. So just think that through. Don't assume it's going to be there, but also don't assume your locality is going to have it on site, and make sure your locality is not assuming you're going to have it on site and they don't need to be there. Next. So some special populations. Increasingly, we're seeing more folks with sensory processing disorders. That's our folks with dementia, with sundowner syndrome, in addition to our population that has autism and other autism spectrum disorders. Consider separate areas to decrease external stimuli. A lot of you use schools for shelter. If you can, is there an interior classroom that they can use as opposed to being in a general population shelter to help reduce the stimulus? Have areas for pacing. This is really important when you have folks with mental health issues. We know that more of the chronically mentally ill are being kept in communities and residing in group homes that may show up at your shelter as well. As anxiety increases, sometimes pacing helps to decrease that anxiety for them and give them something that they can do. So if you've got an interior hallway, again, if it's a weather event or someplace they can pace, that would be really helpful. Light levels, too bright, too low. Think about if it's nighttime or evening, how you can keep lights low yet still have enough visibility for people to safely ambulate. And noise blocking ear protection is really helpful, and it's being used more and more, both with folks with mental illness who have that low level of hearing voices all the time. And we're not talking about earplugs, but think about the ear protection worn by those guys that guide your flight out, that have, the full ear. That helps block out voices. A lot of folks will listen to music on their own earphones, which means they need to keep their phones charged, and that kind of helps keep the voices down, but it also helps decrease that external stimuli that they're getting from the environment and helps calm folks down. Next slide. And that moves us into mental health crises. So consider training staff in mental health first aid. I will say that the mental health first aid class really covers a lot of psychosis, but it doesn't cover what I call the non-psychotic issues, the depression, the suicide. Hopefully, your partners from DBHDS will be partnering with you and have folks available to intervene in these situations, but maybe not initially plan on that, perhaps not being in place initially when you first pull the trigger on the shelter. And remember, folks with mental health conditions can deteriorate very rapidly, especially when they're outside of their normal environment. So think about psychiatric medications that they don't have to be as important as a stabilizing medication as insulin. That will keep that individual safer longer, and it will keep you safer longer and the other folks in the shelter. Some critical issues in the care of the elderly. This became particularly apparent during Florence, where we sent our EMAC mission to North Carolina. The elderly are increasingly a large number of our clients as hospital at home has increased. We've got more folks living at home longer. One of the biggest issues we've seen is hydration. Elderly people on various meds, diuretics, diabetics, hypertensive meds, cardiac meds, can dehydrate very quickly. And so you need to really push hydration and push things that they want to drink. Water doesn't always go over very well, but remember, anything liquid works. Popsicles work. Italian ices work, particularly if you've got spotty air conditioning in your shelter or if it's pretty stuffy. So think about hydration, 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 hydration rounds. The other thing to think about is where you're placing these folks. So cots are low to the ground, and during Florence, we had a lot of folks that were worried about drinking because they couldn't get off their cot to make it to the restroom. The other thing is, if you're using a school and it's an elementary school, they have little itty bitty toilets. So what we found in Florence is our elderly folks just couldn't use those little itty bitty toilets, and we needed the Baptist Men's Association to come in and put in raised toilet seats. And there also were not enough handles around the toilets to allow people to get up. The cots are often made of a canvas type material that can cause shearing as you slide forward to try to get up. For the elderly, that's really hard on their skin. So you need to be thinking about skin integrity, tegaderm. You've seen folks that can just bruise and bleed from banging their arm on a table. Those are the kinds of things that you need to think about. And if you're looking at an increasingly elderly population, incontinence supplies may be a consideration that you need to think about. Both the supplies themselves, areas for folks to take care of hygiene, to dispose of those products, those little things on the back of stalls get full really quickly. So you just need to think about, what do you have as waste receptacles in bathrooms for folks to be able to dispose of these products and have them readily available. And remember, the more dehydrated a person gets, the more an issue skin integrity is. So we also need to think about bariatric shelter residents. So fun fact, standard toilets have a maximum industry standard weight of 1,000 pounds, but wall-hung toilets have an industry standard weight of only 500 pounds. So if you are using a school as a shelter, you may need to check the toilet size, because if they are smaller than a standard toilet, it may have even a less of a weight limit on it, and that is an issue with our bariatric clients. Now, the max weight is theoretical. From personal experience in working with bariatric patients, I have seen them disintegrate at less than 1,000 and definitely less than 500, particularly on a wall-mounted toilet. So those are some things that you need to think about if you've got bariatric folks you need to accommodate. Standard cots typically only hold 250 to 350 pounds. So if you've got standard adult cots, you need to think about how many bariatric cots may you need to accommodate those individuals. And with mobility issues, a lot of folks use power chairs, which are the power wheelchairs. And if you've got an elevated floor, you may have to figure out what is the weight limit for that floor, particularly if you've got somebody on a second story, or if you've got a transport. Even with a wheelchair transport, the van may have a weight limit for how much weight they can accommodate with that electric power chair. Again, it's an electric wheelchair, it has to be plugged in. Power is key. These folks are also much higher risk for skin breakdown, particularly if they're sitting for long periods of time in the shelter. So for pods and shelters, we've got some logistical challenges. If you have to set up a pod, one of the things you definitely don't want to do is set up a pod in a general shelter population where you're giving injections, where everybody can sit and watch the next person get the injection. It's a recipe for mass syncope. So if you can, plan to set up a pod operation away from the general population shelter if possible. Same if you're doing a testing event. You want to make sure that that testing area is in a different area than where you've got the shelter. You've got to think infection control if it's testing. What is the airflow? What is the airflow away from the general shelter population if you're looking at testing for something airborne? And if you're doing a pod, everybody who's doing the pod still needs the same training as they would, including if it was just in time, to deliver whatever you're delivering as they would in a regular pod. So a note about record keeping next. Annex H includes a template for nursing notes. So records have to be stored like any patient record, and the retention of those records depends on the patient's age and what was the procedure that you did. So these folks don't have to be entered in WebVision, but you do have to have a way to retain these records in your health district under the retention schedule from the Library of Virginia. And that information is in Annex H and the link to the retention schedule, because it does change occasionally with what has to be maintained for how long. And then when you're thinking about closing down your shelter operations, these are some of the things that we included when we worked with Michelle Pope on the state mandated shelters, is what could reasonably be considered a BDH. Of course, you're going to work with your DSS partners to case manage these folks as you're trying to close your shelter down. So what we can do is we can provide case management for folks who are in programs under the purview of VDH. So WIC folks who need special formulas, make sure that they have whatever they need to get them to their next destination, particularly if they aren't returning home. We may have PrEP clients that need their next schedule of meds. If they're going to a different area, we may need to do a handoff to the next PrEP client. Our TB clients, of course, will need to do a warm handoff with those to wherever they're going if they're not able to return home. We can also screen folks in the shelter for our LTSS funded by Medicaid. Again, you're going to partner with DSS to do that. They should be right on site. We'll help folks continue with medical resources, particularly if they're going to be placed in an area outside of where they live. But the last thing you need to think about is what are you going to do with those folks that you have in isolation or quarantine that can't return home. If they can return home, great. But if they need to go to another place, if you're closing the acute shelter and you're looking for something a little more long-term, what are you going to do with those folks in the interim? You need to have a plan. And then talking a little bit about self-care, we learned when we sent folks on our EMAC mission to North Carolina, the folks that had the least amount of training and the least amount of preparation had the toughest time while they were there. So training and getting people to know what to expect, I can't emphasize it enough that it's so important that you walk through these things, even if you think you live in an area that quote unquote will never open a shelter. Because remember, we learned with COVID, we can move people around if we have to. So this is an important skill for everyone to have. But when you look at this continuum, and it should be familiar to most of you, you need to think about where your folks are. The more prepared they are, the more ready they are, their sense of mission, they know about the go bag, they've practiced where they're going to report to, they know what to expect when they get there, there's not that anxiety, the better off they're going to do. But the longer a shelter is open, or the more repeated events that you have, the more you really need to check in with your folks and see how they're doing. This has been a real problem for public health out in California, where fire season used to last for a couple months, and now it seems like no matter where they are in the state, they're evacuating somewhere, and it's just a constant state of stress. So with all we've been through with COVID, I think you're going to be seeing a lot more about looking at this continuum and what the acute care community has done to really check in with folks to see, are you in the green zone? Are you in the yellow zone? Are you in the orange zone? Or you really have lost it and are in the red zone and we need to pull you? And really encourage people to think about where they are on this continuum and give people breaks. And on the next slide, I'm going to talk about giving people breaks. So tough it out is not a strategy to embrace. We saw this with Florence when we had some nurses that were stuck in a shelter for 24 hours and nothing had really even happened yet, just because, quote unquote, we didn't have enough staff. We know from all the research that 12-hour shifts are pretty much the max for nurses, and we're looking at error rates throughout the industry. Luckily, switching to electronic health records has really shown us that by about hour 8, errors start to go up. By hour 10, they increase even more, and anything you go beyond 10 hours, they really are increasing. You've got decreased judgment, you've got fatigue, you've got everything from alarm fatigue, where they're not even paying attention to the alarms anymore, to I don't care, I just want this shift to be done, whether you're the most dedicated person or not. So really, 12-hour shifts, strive for that when you're planning for your shelters to be the max, not the minimum. Think about your rotations, practice with your MRCs and others. How can you get more people in there? If you need to, think about early on in the response, can you get assistance from other places in the state? We know from COVID that we called on folks from central office and they were able to fill in a lot of our clinics in our health district. So try to stick to that plan to make the 12-hour shifts the maximum, 8 hours if you can. If you can't rotate people out, make sure you're taking care of the person in the shelter by hopefully arranging a place where they can go to a different classroom, some place where they can decompress and not just sleep in the general population shelter. Because remember, they're not just in there with everybody else, they're trying to manage everybody in the shelter. Institute some nursing shift daily huddles if this goes on for a couple of days. Check in with folks, see where they are on the continuum, and plan constantly for what you can do to get them some stress relief and refer people to things like EAP if you need to. Next slide. So we added this after the last training, but this is the training resources where NXH is there. I believe they're going to post these slides as well, so you'll be able to click to all the links that I've put in there. And the recording will go up on there either later this week or early next week, so that folks who haven't seen the recording can watch the recording. And then the last slide is just, does anybody have any questions? Well, I must have covered it all.
You can put your questions in the chat or click on mute. All right, well, thank you very much, Janine. We appreciate you sharing all your expertise with us, and we hope everybody has a nice afternoon. Thanks for your participation.